Hello, I'm Natalie Blagowidow, and I'll be speaking today about pregnancy in classical Ehlers-Danlos syndrome. I'm an OBGYN geneticist. I practice at the Greater Baltimore Medical Institute in Baltimore, Maryland. I have no disclosures. And the things I'll be talking about is planning a pregnancy, then issues that come up in pregnancy, ranging from symptoms that can be exacerbated a little bit, but things that many pregnant women experience, and then certain things that women with classical EDS are perhaps at a higher risk for, and that can vary, and we'll talk about that. We'll talk about delivery, both vaginal and C-section, advantages and disadvantages of both. And finally, postpartum issues that come up, and we'll conclude with just sort of management guidelines for pregnancy and delivery. So before pregnancy, it's important for all women, including those with classical EDS, to review their medications. Many individuals use herbal and nutritional supplements, and some are not safe in pregnancy, so you want to carefully go through those. Women on seizure medications or any medication, you want to take a look. Is that potentially harmful to the fetus? Can you change to a safer medication? And particularly with seizure meds, you want to reduce the number of meds if possible. Of course, immunization is important, and these days, I have to particularly mention getting the COVID vaccine. Absolutely, you can do it before pregnancy. If you're pregnant and you haven't been vaccinated, please get that, and the booster, of course, is recommended as well. All right, so the other particular issue with connective tissue disorders is to make sure that the heart is in good shape, and that involves getting an echocardiogram. We're looking at things like the mitral valve, which may not really require any particular intervention, but if the aortic root is dilated, women with that concern may require medication and close monitoring throughout the pregnancy. Now, hormonal changes affect every organ in your body when you're pregnant. Progesterone levels are higher, and progesterone will relax blood vessels, the gastrointestinal tract, smooth muscles, and that leads to symptoms such as gastrointestinal reflux. This is very common, of course, in any pregnancy, but for women with Ehlers-Danlos syndrome, it can be even worse. That can be treated in a routine way, avoiding spicy foods and opioids, using antacids. So no special recommendations, but just something to anticipate. Blood vessels, of course, will respond to these hormones. And so varicose veins can be a real issue. And I've definitely talked with patients who've had significant problems with those, including particularly the vulva. So compression stockings will really help the legs, but the vulva can be a challenge to take care of. You want to avoid deep vein thromboses is the reason we're really concerned about treating, as well as symptom management. Increased bleeding is another problem that occurs in women who are pregnant, and we particularly see that with classical EDS. So just anticipate that nosebleeds, dental procedures, just things that you may experience when you're not pregnant may be tied in with more bleeding when you are pregnant. The other hormone that increases in pregnancy is relaxin. And relaxin already is present in the body, but in pregnancy can exacerbate pre-existing problems. So for example, if you have joint laxity and pain, that can worsen. So hypermobile EDS is where many of the studies have been performed, but we see it with all forms of EDS, including classical. So the recommendation might be treating with physical therapy, using special devices to help stabilize the pelvis, and just hoping to be aware of it and to just use the support that you can for that. And the particular pain that individuals experience is every pain in the pelvis. So it's increased lumbar lordosis. Good shoes are important to help treat that and to help alleviate low back pain, pelvic pain in every joint, and then even groin pain that radiates to the lower abdomen and hips, and coccyx dislocation can occur. The next slide shows the pelvis, and you can see the slide that says normal pelvis shows the different joints. The image to the right shows the gap there in the middle of the symphysis pubis that can open up. Those bones can actually rub on each other and create a great deal of pain, but that's not to dismiss every other joint that you see in these images. All of them can become looser and create issues for individuals. So again, physical therapy and sometimes actually some sort of binding can be helpful. Some individuals with connective tissue disorders, including classical EDS, have POTS, postural orthostatic tachycardia syndrome, where the heart accelerates with a change in position. Symptoms include dizziness, nausea, palpitations, fatigue, fainting, and pregnancy. The cardiovascular changes, such as peripheral venous blood pooling, can lead to reduced diastolic blood pressure, and symptoms of POTS can worsen with pregnancy. Now they can also improve. So how can they do both? Well, because you have fluid retention in pregnancy, you can actually feel better if you have POTS, but that tends to be kind of in the late parts of pregnancy, third trimester, after 28 weeks. In early pregnancy, especially for individuals with hyperemesis, symptoms can worsen, and with the pain of labor as well. So it's important to pursue the treatment of adequate salt and fluid intake, adequate anesthesia for labor, and to avoid bearing down if possible during that delivery stage of labor, to avoid that POTS exacerbation. Now, the other issue that comes up in particular with connective tissue disorders and in particular with classical EDS is the question of an increased risk for premature rupture of membranes. This means that you break your water before 37 weeks of pregnancy. So why does that happen? Well, the amnion has 5 layers, which includes a layer that's mainly made up of collagen fibrils. And the theory in EDS is that these fibrils are altered and can lead to premature rupture of membrane. And so here's a blown up slide that shows all the different layers. And you can imagine if a couple of those layers aren't functioning normally, you'll have a complication of them breaking when they shouldn't. And so studies over the years have reported increased risk for premature rupture of membranes, increased risk for preterm delivery. And there was a good study by Lind et al. Out of the Netherlands who found that when the fetus was affected, there was definitely an increased risk for this rupture of membranes, whether the mother had EDS or not. The father transmitting it to the mother can, with the mother unaffected, can still lead to these risk factors because the fetal membranes are, amniotic membranes are actually fetal in origin. The good news is that more recent studies have taken a look at this particular issue and have not really found an increased risk, specifically for classical EDS. But we sort of feel that you should still just keep an eye out for it because we don't want to overlook this problem. And it may be perhaps the particular genetic variant you have. One group may have a higher risk, one group may not. So it has still some research that needs to be done to clarify this. And we'd rather err on the side of caution and just keep an eye out for this risk factor. Now, the other sort of related factor is the incompetent cervix. So here we're looking at not the fetal membranes or the amniotic membranes, but the cervical tissue that can contribute to a premature delivery. And the theory is that the abnormal connective tissue, again, the collagen in the Ehlers-Danlos patients, leads to a cervix that will loosen up and be incompetent. And relaxin does play a role in cervical integrity, so that higher level can, in pregnancy, can be a factor as well. What our recommendation is the cervix be monitored with vaginal ultrasound every 2 weeks between 16 and 22 weeks of pregnancy. And here's an image where you see the normal cervix on the left and an incompetent cervix on the right. And the incompetent cervix has this membranes of the fetus dropping right in, while the one that's normal, the cervix is closed, and see the length is being measured here. So it's a pretty easy scan to do and can really detect a problem if it's identified. The other association with particularly, again, classical Ehlers-Danlos syndrome is if the fetus has inherited the cEDS, it is more likely, he or she is more likely to be in an abnormal presentation such as breech, which is upside down, but shoulder presenting, forehead, face also can be seen. So it's not inevitable that this will happen, but this is, again, something your obstetrician or midwife should be aware of and deliver the baby appropriately. Now, so what kind of delivery should be planned? Well, in terms of vaginal delivery, there actually can be some advantages to having EDS. If you can say that the second stage going faster is an advantage, there's less chance that you're going to need forceps or vacuum delivery. It's not, the pushing phase shouldn't be really prolonged. There's less chance statistically in some studies that the anal sphincter will have a tear into it. The joint laxity might permit the fetal head to travel more readily through the pelvis, and the just looser tissue allows just the fetus to pass through the vaginal canal more readily. The other thing that people worry about, though, well, wait a second, the fetus is going through the vagina, it's passing through this fragile tissue. Is this going to create problems down the road for the pelvis? So when they've done general studies with hypermobility individuals, it was found that down the road, 5 to 10 years later, pelvic prolapse was not an increased risk compared to the general population, but it's certainly a common concern with cEDS. And the question is, can we by avoiding the vaginal delivery, reduce those concerns? And it's not clear that we can. So the weakened pelvic floor, of course, the things that can occur are the cystocele, the bladder dropping, the bladder distending, stress urinary incontinence due to that. The uterus can prolapse, the rectum can prolapse. So these can be major issues with a lot of symptoms and concerns for women. Pelvic floor exercises can help, the Kegel exercises and so on. And having worked with some expert physical therapists, there really is a lot they can offer. You would want to see one with a particular knowledge of EDS to help you. Prolapse, however, can occur in women who have never had a pregnancy and can occur even in teenage years. So prevention is good with these exercises. Treating things as they occur is good, but avoiding a vaginal delivery will not necessarily avoid the issues of pelvic prolapse. So what about a C-section then? If you think that maybe you can avoid that pelvic floor injury, if that put you into a better category, well, you can avoid labor and you can avoid the pelvic floor injury. As I said, it may or may not help pelvic floor prolapse problems. Wounds, however, from the C-section may heal slowly or break down, and abnormal scar formation can occur. And so that's a concern with the cesarean delivery. Certainly, however, if the fetus is breech or one of those other abnormal presentations I described, if there are really significant joint issues or poor hip mobility, C-section is recommended. And the other thing that comes up with connective tissue disorders is a concern about anesthesia. Older studies said, oh no, don't do regional anesthesia. There can be complications. And really, that doesn't seem to be the case. So it's perfectly safe to do an epidural anesthetic. And the only contraindication might be if there's scoliosis or spinal surgery. The one thing that you should know, and you should let your doctor and anesthesiologist know, is that increased doses of anesthesia seem to be required in some individuals. So they shouldn't be surprised that you're not getting relief with a standard dose. And if that's discussed ahead of time, everybody's sort of prepared for the correct dosing. And I want to make a point, if you look at the image, you can see there's the spinal fluid. So an epidural anesthetic is outside of the spinal fluid-filled area and doesn't penetrate that membrane. So for those people who are concerned about developing a chronic leak from a spinal anesthetic, avoid the spinal anesthetic, which sometimes is used for elective C-sections, and instead the epidural, which stays out of there, will avoid that whole issue. All right, now what about bleeding? Bleeding is something we're concerned about with significant blood loss, meaning if you lose a liter of blood or more, or if you require a transfusion. Classical Ehlers-Danlos syndrome individuals are at a higher risk for increased bleeding. As I mentioned earlier, the nosebleeds, but certainly with delivery as well. And so that can be during the labor or cesarean section, or even afterwards, heavy bleeding in the postpartum stage. So it's important to know the options you have for treatment, and DDAVP and tranexamic acid are two therapeutic options that aren't always first line for the doctors and specialists managing your delivery. So it's good to, again, educate them, make sure they're aware of those options. I have seen these actually used in individuals who don't have connective tissue disorders. So I think there's more awareness of their availability and usefulness in these situations. All right, now just one of the other issues with classical EDS is that bruising, and some women take vitamin C in a fairly high dose. Now, vitamin C is not harmful to a fetus, and so the standard recommended dose of 80 milligrams in pregnancy can be boosted up, and the high dose that individuals take is up to 2,000 milligrams. Now, if you go even higher than that, you can have GI distress, which you definitely want to avoid. But the high dose, if it's maintained throughout the pregnancy, can actually affect the newborn baby, because the baby's all geared up with this higher vitamin C and is ready to excrete these higher levels that it doesn't need. And then there have been a couple of cases of scurvy. So the recommendation is, if you're taking vitamin C in a high dose to avoid bruising, it's not going to harm the baby except for this one effect I just described. So you want to taper vitamin C slowly at the end of pregnancy. And remember that it's a water-soluble vitamin. So if you're skipping it, you yourself can experience these, your body will excrete the extra levels and you might end up with too low a level. So you want to be on a steady dose. And if you're adjusting it, do it, over a little bit of time, not just one day say, okay, now I'm not taking an extra dose. All right, so the summary of all these issues are premature rupture of membranes, cervical incompetence, breech presentations. The other thing is actually with vaginal delivery, that perineal tears can occur. So you really want to have an attentive person assisting in that delivery to avoid tears and to avoid doing an episiotomy whenever possible. We talked about prolapses, certainly an issue in cEDS, but we just don't know that pregnancy itself, whether it truly increases the odds, or is it just that the risk is so high to begin with. All right. And then I would like to just give a mention to Tenascin C1 EDS due to the Tenascin-X deficiency. There have been specific studies, just 23 pregnancies, and that includes a decent number of those were more than a patient having more than one child. And what they found are kind of the things we've talked about with some had pelvic prolapse and tears, one had a premature rupture of membranes, bleeding was an issue. So things we've talked about, as well as that second stage, it's good that you don't have to push a long time to deliver a baby, but if it's precipitous, that's not great, where the person doing the delivery is, not even in the room with you. So that's something to keep an eye out for any woman with EDS. But I would mention that it's very small numbers here, but there were 3 pregnancy losses. So I think the recommendation to draw from that is some increased fetal monitoring in the 3rd trimester, biophysical profile, non-stress test, that sort of thing, to check for fetal well-being, if there's any way to anticipate that. And again, this could be just a sampling, very small study, and this is what happened, but it's something to, I think, again, to try to keep an eye out for. All right, so to conclude, these are the things you want to do. Get the heart evaluated before conception if possible, or certainly as soon as you know you're pregnant, to make sure there's no aortic root issues. And if there are, get that treated. Plan a delivery at a hospital with full services. And that's mostly that concern for bleeding, but for some of the other issues that we've discussed, monitoring the cervix between 16 and 22 weeks. And when I just mentioned that monitoring, sorry about the typographical error, but preterm labor, and monitor for fetal well-being after 28 weeks of pregnancy. Consider a consultation with anesthesia, especially if there's a history of spinal problems or of POTS. But if you have any concerns, it's always nice to talk to these folks ahead of time, rather than in the throes of feeling lots of labor pains. During delivery, gentle pushing to avoid triggering POTS issues, also to try to avoid injury to yourself in terms of tearing, appropriate positioning of legs to avoid hip injuries is helpful. And keep in mind that if you do have a regional anesthetic, that you can't really tell where your hips are. So you want to kind of get things in position or figure out how you're going to be before you get the anesthesia. Avoiding elective episiotomy and instrumentation and the medications that can be helpful if there is bleeding. And then in terms of the cesarean section, again, just like for vaginal delivery, gentle handling of the tissue, double layer closure of the uterus so that the uterus stays closed to promote healing. Retention sutures have been advised. These are sutures that are actually left in place for 2 weeks and then can be removed. They are external, a portion of them, and then they're just removed after a couple of weeks. And to use permanent suture, not sutures that dissolve. All right. And that is the end of the slides. And thank you so much for your attention. And then I'll look forward to answering any questions that you have from this talk or just in general. Thank you.